It's 4:05, and we start this webinar on health and social responses in prison. It's the last webinar of our series this year, and also the webinar of the conclusive part of the COPOLAD project, our European Union Drugs Agency collaboration with the Latin American countries. I'm thankful for having been asked to open this webinar, and I won't take more time. It's a very important subject for us. With our new mandate, we are looking forward to be able to better monitoring health and social responses. And what happens in the prisons is very important from this point of view, because prison population unite several different vulnerabilities and has a special role for what happens in the wider community, in the outside community. People in prison has an increased risk of infectious diseases, and at post-release an increased risk on about opioids and other drugs overdoses. And people working in prisons needs to be supported with appropriate training and general evidence-based interventions. So I don't take more time from our audience, and I would give the floor to Sofia Ribeiro, who is also the project manager for our COPOLAD collaboration. Sofia, the floor is yours.
Thank you very much for this warm welcome, Marika, and thank you, first of all, to all the speakers and to the team that made this webinar happen, and also to all the participants that joined us today. As Marika was saying, perhaps not the ideal time for some of the regions, but the best possible time we could accommodate to take into account the time zone difference between Europe and Latin American and Caribbean countries. It's my pleasure to share this webinar. The idea today is to discuss health and social responses in prisons in different regions of the world, focusing on Europe and Latin American and Caribbean region, but also with some insights and examples from other regions in the world. Before I move on to talk to you about the speakers that we're going to have today, a few logistic considerations. This webinar is being recorded. Also, there's interpretation English to Spanish. You can click on interpretation that is at the bottom of the Zoom and select your channel. And also there will be the slides. You will see them in the main channel in English if you click on the speaker. If you want to see the slides in Spanish language, you look at the top of your Zoom screen and you'll see Silvia Podgorska. You click on her and you will see the slides also passing in Spanish. So you're free to choose between the two. Today we're going to have three speakers. Linda Montanari from the European Union Drugs Agency, then Carina Ferreira Borges from WHO, and we're also going to have a recorded intervention from Corina Giacomello, who's going to give an overview of the challenges in the Latin American and Caribbean region. So without further ado, I would like to invite Linda Montanari, who is a principal scientist at the European Union Drugs Agency, who's going to deliver a presentation on the key highlights on gender, but also on prisons and focusing on social responses and the work we do at the European Union Drugs Agency. Linda, the floor is yours.
Thank you, Sofia. Thank you, Marika, for inviting me to this webinar and to present. I can see the Spanish version. I don't know if you can show me or should I put, if you can show me the English version, because I will speak in English.
You can click on Mete's screen and on the top of your Zoom, and you will see the English version.
Sorry. Meta. Yes, sorry. Okay. So again, thank again. I will present you an overview of what we know about prison and drugs in Europe and try to give a focus on social responses. And the next slide. So first of all, among the around 800,000 people that were in prison in 2021, according to the latest statistic of the Council of Europe, around 18% were in prison for drug law offenses, which means for offenses for drug use and drug trafficking. However, not all of these people are using drugs or have problem with their drug use. In the graphic, let's say on the right, you can see the possible group and interlink between drugs and prison. So in prison, there are people that are there for drug law offenses, some of them using drugs and having problem with drug use, with large variation between countries, as you can see from the map. There are also people that are in prison because of offenses committed to support the drug use, the so-called acquisitive crime, and they're using drug, and usually they have problem with the drug use, but there are also people that are in prison for other crime and are using drugs. The next slide, please. What we know is that the prevalence of drug use among the prison population is very high. And you can see this in the table in the right, where we compare the maximum percentage of lifetime prevalence of illicit drug use in prison population and in the general population. You can see that this can go from more like the double of the percentage for cannabis, or almost the double, and many more time higher for other substances, including cocaine, amphetamine, heroin, and also I put MPS because it is an issue now in prison. But for heroin, as you can see, for instance, while in the general population, there is the value is always below 1% of those who have experimented with heroin use is up to 36% in the prison population. In the graphic in the left, you can see the different values in the different prevalence in the countries reporting this data, also comparing, you have the violet line, let's say, with the prevalence in the prison population, and the green one in the general population, and then the excess in drug use between prison and general population. As you can see, there is an excess in all countries with large variation between countries, and these large variations may depend on several factors, including the actual differences in the prevalence in the prison population, but also in the general population, because there is a certain mirroring between the patterns in the two groups. But also there are methodological differences in the way the data are collected, and I will talk about this afterwards. The next one. So if the previous slides was presenting the data on drug use before imprisonment, and this is important also from a public health perspective, because we have to consider this population, as I say, that is largely affected by drug use and drug problems. There is also drug use inside prison, because first of all, many people, when they enter prison, they stop using drugs because drugs are also scarcely available or not available in prison, and this is a prohibited behavior, of course, but also others reduce the drug use, or other continue to use drugs, and others change the drug use patterns. For instance, they tend to use different type of drugs, usually more tranquilizer drugs, because of is more, let's say, appropriate, adapted, easy to use in a prison context, or they may start to inject because is more efficient. So since the drugs are scarce inside prison, so injection may be a more efficient way to use. And there was some research showing that there are also some people adding other substances when they enter prison, and some also start using drugs inside prison, but data are a bit scarce on this because it's difficult to collect data on drug use inside prison for different reasons. However, in the publication that we report report we published in 2021 in the 11 countries that reported data on drug use inside prison. All the country report some form of drug use. And you can see also there is a variation with a maximum value for cannabis and the lower for cocaine or amphetamine, depending on the countries. And also among these country reporting drug injection inside prison, 7 out of 13 report some injection, from 1% to 14% of these people injecting drugs. And we know that injecting drugs, it is a risky behavior in general, and even more inside prison, because the injecting equipment is scarce, so the people tend to share the injected equipment. The hygienic conditions often are scarce. I think Carina will talk more about these in her presentation. So it may be very risky from the health point of view. In the map on the right, you find the result of a study that we have conducted in 2018-17 on use of new psychotic substances inside prison, because there was this emerging phenomenon starting already in 2013-14 of use of especially synthetic cannabinoids, because of the scarcity of the availability of substances inside prison, and the fact that synthetic cannabinoids that were not detectable, now there are more synthetic cannabinoids that are detectable inside also by drug test. So there were people starting to use these, and this was causing several type of consequences for the health of the people, also because often they didn't know what they were using or what quantity of the substances were using, but also for management and organization of prison. Lately, what we found, and this is this small leaflet that you found on your bottom right, regarding the use of nitazene inside prison, that was emerging in some countries. In Ireland, there was an emergence, then it was not very clear if it was in fact nitazene or something else, but also in UK we know, and in other countries was reported, which is a very potent synthetic opioid, so which can cause overdose and other problems. The next slide. One issue that I would like to highlight is the women, in the relation between women and drugs inside prison. We know that women represent only a small percentage, at least in the European prison they are around 5%, but the largest proportion of women, they are in prison for drug law offenses. Also, the history, this very vulnerable population is a small but very vulnerable population with high prevalence of violence, including physical, psychologically, and especially sexual violence. You can see in the graph the comparison between the prevalence of violence in the general population and the prison population, that you can see the women in prison who were victims of violence at a much higher level, and in very repeated during their life, with these adverse episodes that have a cumulative effect on their level of vulnerability. The next slide. And one of the response to the trauma is the drug use, usually used to alleviate the trauma from the violence. In this graph, maybe not so clear, on drug use among people in prison, males and females in 6 countries using the same instrument, you can see that the prevalent, there is an excess compared to the general population in all the countries, and the excess is particularly high for women. The next slide. And this is particularly visible when we look at opioid use, where the percentage of men and women are more or less similar, even higher when we look at opioids other than heroin in the graph on the left. And also another important information is that this population is also having risky behavior at a higher extent compared to the males. So again, it's a very vulnerable population, often invisible, often not addressed by intervention that are appropriate to them. So that should be considered, and more research and more analysis should be conducted on this group. Next one. Then going back to the males and females, so the total population, and I think, again, Carina will really go more in depth on this health status and health intervention. We know that they carry a high burden of diseases in general and drug-related diseases in particular. We can see here the prevalence of HIV and HCV among people who are in prison, and that also with large variation, these values are much higher than what we find in the general population, but also psychiatric comorbidity is a big issue. There are no harmonized measures on this issue, but in particular on mental health, but we know that the prevalence of psychiatric comorbidity is very high in this population, ranging from 20 to 90%, because this is mainly related to the large variation in the method for data collection. But we know that there are many people that are not just using drug and have heavy problem related to their drug, but they have also serious and severe mental health problem that can be a risk for suicide, self-harm, and reoffending. The next slide. Of course, the more severe consequences of drug use and their interlink with imprisonment is mortality. And you can see two sides that we should think about and look at it when we think about the intervention for the prison population is the mortality inside prison, with suicide being one of the leading cause of deaths inside prison. And a French research report that 78% of deaths inside prison are violent deaths, and of those 78%, 1 in 10 are due to intentional or accidental drug overdose or intoxication. So the drugs is involved in this. And with NPS, we may have more of these deaths in the future, and we should be more prepared to address this issue. Another issue that is very known since long time for those that are working in prison or with the prison population and the drug use is the mortality after prison release. We know that in the first period after prison release, there is a very high risk of dying for a drug overdose due to the reduced tolerance. So intervention should be really addressing this issue. The next slide. But what we have seen in all this data, that we have much more data now that compared to 10 years ago or 20 years ago, but still there are issues of comparability. There is still lack of data, especially when we look at drug use inside prison. So there is a need for more harmonized data. What we have done at the European Union Drug Agency is to develop a monitoring framework for monitoring drugs in prison. In particular, we have developed a questionnaire on people living in prison that is a model questionnaire available in several languages, in short and long version, that is already used in around 1/3 of the country and is accompanied by methodological guidelines. And we advise the country to use this questionnaire in order to improve the comparability of the data. And the same for European Facility Survey questionnaire in prison, where it is in the phase of finalization, but has been used already and piloted in several countries, where we collect data on intervention that are addressing drug problem inside prison. The next slide, please. Then when we look at intervention, we know that in this publication, the Prison and Drugs, that you can find in internet, we dedicated one chapter, the chapter 6 on available evidence and good practice addressing drug use and related harm in prison setting. What we found is that there is scarce evidence of the intervention, and the scarce evidence is mainly related to the fact that there is little research, but also we have to wonder if there is the need for specific research for prison setting, or is not more the need for study on the feasibility and the acceptability of some intervention inside prison. What is proven, and this was also reported in the public health guidelines that were co-produced by the CDC and at the time EMCDDA, combining systematic review and expert opinion, is that there are two type of intervention that have proven effective as the inside prison, which are the opioid agonist treatment and death prevention and treatment of infectious diseases with several package of intervention. However, this is still not very implemented in prison, including in European country, but we can see in the next slide what is available. So this slide report the number of countries where the different type of intervention, you see a list of intervention, is officially available. So you can see that there are interventions that are available in almost all countries. We work with 29 countries, 27 member states plus Norway and Turkey in Europe, like infectious disease testing or opioid agonist treatment continuation from the community, which is available in all countries except in Slovakia. There are 2 countries that were not reporting information. But then when we start to look at other intervention, including, for instance, initiation from the community, the only 23 countries report this type of intervention, at least officially available. And even less when we look at some harm reduction intervention, including needle and syringe program, which is available only in 3 countries. In fact, 2 countries at national level and 1 country only in 1 prison, or naloxone distribution, and we have seen how this can be an important intervention for preventing mortality after prison release or inside prison, and other type of intervention. So there is an issue of availability. Next slide, please. Also, many of these interventions that were implemented in the community were implemented in prison much later. And this, you can see, there are the abbreviation of the European country. I don't know if you managed to recognize them, but like, for instance, the Netherlands introducing is 1967 already opioid substitution treatment, and it was only in 1985 was introduced in prison. And there are countries that have just introduced in prison, like Lithuania, because there was a big outbreak of HIV inside prison, so they introduced opioid agonist treatment. So there is the delay for the introduction of intervention. The next slides. And also the coverage is very low. So you can see here is the coverage of HIV and HCV testing. First of all, there is little information. That's why it's really important to implement this instrument for collecting information. But also the coverage is very low. When we say full, it means more than 90%, and you can see there are really few countries in the map with full coverage, and the rest is very low. The next slide. Then I try to focus to have a bit of analysis of what the country report and reported in the last report on psychosocial intervention. So there are 4 types of intervention that can fall in these categories: individual counseling, group counseling, therapeutic communities, and peer-to-peer intervention. In several cases, maybe some of these interventions are combined. So you have group counseling within therapeutic community or also individual counseling. What we have seen is that individual counseling is officially available in 27 countries, providing different type of approach, usually motivational interviews or coping and social skill training, behavioral and self-control training. And but this doesn't mean, again, that the coverage is large, and these are done regularly because we know there is a lack of staff inside prison. Group counseling is available in 9 countries with, again, usually cognitive behavioral therapy, and also there are 23 3 countries where there are therapeutic communities. This is distinct from what is called drug-free units, so where just units inside prison where the people cannot use drug, and for that reason they have certain condition or privilege, but they are really communities where it's possible to do some type of activity. And finally, peer-to-peer intervention that usually provide peer support, education, monitoring, and they especially they help to increase the trust of the people living in prison to implement some type of intervention. I will conclude shortly because then I think I'm too long. The next one. This is the linkage of external care, which is another very important point to address. And you can see this distinct between linkage to social care, linkage to HCV care, and to HIV care. And as you can see, there is most of the country, they are reporting that there is some linkage with different type of model. Here some example, like in Austria, external services are operating inside prison, or in Denmark, they have the so-called import model where the external service must cooperate with prison services following national guidelines. In Finland, everyone treatment should continue after prison. And also in Slovakia, there is, after release, a person should have contact a so-called social curator. However, I would like to highlight that among the 3 linkage of care, the social care is the less available in the countries. The next slide. One just initiative that I would like to briefly mention is this toolkit that we are doing together with the CDC and with the Advisory Board of several experts, including WHO Health in Prison Program, that we would like to provide for the health professional working in prison, and is a really practical toolkit for the elimination of viral hepatitis in prison. Within this toolkit, we also identify 5 models of care of a good example of good practice that are implemented in different, as you can see, in different cities in Europe. And each of these models focus on a specific issue, like linkage to care, vaccination, harm reduction, etc. The next one. We are also trying to develop training, and also other institutions are doing this. We have developed a package that was piloted but not implemented yet, based on our report on prison and drugs in Europe, as I say, that is available in internet and is following a bit the structure of the chapter, and is foreseen to be an online training for professional working in prison, very basic and short and easy to conduct, to carry out, with an introduction, some learning outcomes, some study material, including annotated slides and optional resources. And the next one, I think, is the final one. Yes. So just to highlight some key issues, drug and prison are closely interlinked with people who use drugs that are overrepresented in prison. They have high burden of physical, mental disorder and social problems. Drug use in prison exists and pose security and health problem at the same time, which is one of the dilemma when we talk about prison and drugs. And also we have to think that people in prison have several social vulnerabilities. So drugs is just one of these. And so it would be important really to address the social issue inside prison, always considering also that when we put people in prison, we have to balance the cost and benefit of incarcerating people, especially when they use drugs. So thank you very much. I think the next slide is the last one. And if you want more information, you can find in internet all these resources. Thank you.
Thank you very much, Linda, for this very comprehensive presentation, and also for highlighting many times, and particularly at the end through your summary, how complex this problem is and how we should look at it from different angles, not only during the time that people are incarcerated, but to all the conditions that lead to incarceration, but also to what lies around and what's the impact for the society and for the families of people who are incarcerated, and for also the solutions that we should offer for people who were incarcerated and are back and should have also opportunities for follow-up. We will go first through all the speakers, and then we'll have plenty of time for questions. So if you have questions for Linda, park them please, or write them in the chat, and we'll go through them at the end. So without further ado, I would like to call our next speaker of today. The next speaker of today, it's Carina Ferreira Borges. Carina Ferreira Borges is from the World Health Organization. She's with a program on not only on prisons, but also alcohol and illicit drugs. Carina, the floor is yours.
Thank you very much, Sophia, and thank you for the invitation. Good morning, good evening, good afternoon, depending on where you are, and it's a pleasure for us to be here and to share with you some ideas and best practices around health and social responses related to prisons. So thank you for my slides. And now let's see if I can control. It looks like, yes, I can do it. Let's see if it works. It does work very well. Okay, so in my agenda for today, I'm going to cover 5 points. I'm going to start a little bit with an overview of the health status of the prison population, and then walk you through some of the issues that we find in this very vulnerable population, which is basically linked to inequalities and many of the challenges that we see as well, not only driven by the health status of the people that are in prison, but also the contextual challenges that we see around prisons in the world and with countries with whom we work. And then I'll talk a little bit about best practices and some of the work that WHO is doing. So let me start with the health status, but before that, let me start with the basics of the work that we develop in WHO, which is basically to situate prison health as a public health approach rather than, a clinical approach or an approach that is very narrowed, focused on the contextualized situation of people that are in detention. Why this is important? Basically, because first of all, if we apply a public health approach, this means that we are also being based in our interventions on principles, on basic health, public health principles that should guide the interventions that we drive in prison health. And this is important because the main public health goal of doing interventions in prisons should be about reducing and eventually, I would say, end the disparities that we see among this population, and also the availability and in access of health services of people that are in prison. And this disparity has a huge impact also because it is about reducing the excessive mortality and existing morbidity that we see in this context. And as such, we should be also focusing not only on reducing the immediate mortality, for example, but looking at what would be the long-term solutions that we would like to see. And again, I think Linda mentioned one of the reasons being that we see a lot of excessive mortality also when people go out from the prison settings. So this public health approach is wider than just focusing on the prison. And again, it should be based on focusing on those long-term and generating long-term solutions. It should also ensure that it's based on data, on basic data that we gather, but also on intelligence that will help us to identify what are the key needs that are needed for this population. And also this includes the inequalities, and it should be rooted, of course, in the evidence of effectiveness of interventions that can help us tackle the problems. Then another principle which is important if we talk about an intervention that is based on public health principles is to ensure that the health and human rights of people that are in prisons are considered. And this means limiting discrimination, limiting stigmatization in prison, and removing all the barriers, all the impediments that people have to access the needed care, and also to promote the professional autonomy and the clinical independence that is needed for the health workforce that provide healthcare services in prison. And this is in line with fundamental provisions of medical ethics, but also of international standards and human rights principles. Finally, a third principle should be to minimize the negative impact that comes from the fact that people are incarcerated and the impact it has on their health. So imprisonment, we know that in general renders people in prison much more vulnerable to health risks and exposes them to potential hazards and higher stress levels that can be compounded by also very poorly planned release from custody back to the places where they used to live, and many times, to the former environments where they come from. And this, of course, has an impact, again, in the outcomes that we see from people that are living prisoners. So these are basic principles that we have been reaffirming, and we have been very much focused not only in collecting the data, but really making sure that we bring this public health approach, and also that we bring good governance. We call it good governance principles, because they are fundamental for the care of people that are in prison. Okay, good. So, why also important to talk about governance? Because we have a context that has multiple needs. It is very complex in terms of the environment, and we need to make sure that we collect the complexity of these needs, and we are able to deliver and support the member states to deliver on these complex needs. And of course, we know that there's very high level prevalence of infectious diseases, of chronic diseases, mental conditions, substance use disorders, but also that we have people that suffer from learning disabilities, and many times from even a poor mental health condition. So these are all important and complex needs that require a more structured public health approach that would put, again, prison health, operational and enabling environment at the center to be able to deliver on and to meet those requests that are there in terms of the prison setting. So what we have been doing, it's not just underlining the importance of prison health as a public health and all the principles that come with it, but also looking at how we can improve data collection in prisons. And we have established a prison health framework. This framework is basically linked to assessing the prison health system's performance. We are based on the fact that we have, as WHO, developed an assessment for health systems performance. So what we did was basically to look at it from the lenses of the prison system and see how we could support the member states in collecting data in the different pillars of the health system's performance, so that we could support them in putting in place the policies that can be more effective for each of the pillars. So if you are interested in more details on the health status of people living in prisons in the European region, you can scan the QR code here, and then you'll have more detailed information. but otherwise, you're also free to look at the paper that we published on the framework for assessing the system. And this allows us to get very precise information from the member states regarding some of the inputs, outputs, and outcomes that we have established that can allow us to assess the prison health system. So if we look, for example, at the inputs, what we call inputs, it's basically, what is it that we have, in this prison health system that is important for the system to be able to deliver. So we know that one of the key things is, the workforce, and it is very important to be able to talk about what is it that we have in terms of the healthcare systems in prison settings, in terms of the workforce that is available to support the people in prison. And as you will see here, we see that the system is very well furnished in terms of, the nurses, physicians, psychiatrists, not so much in terms of the dentists, but what is important here to consider is these principles of equity and equality. So basically, we know that we have the Mandela rules, Nelson Mandela rules, they refer to the equivalence of care, and the equivalence of care is focused on having the right to access the care as the same right as those in the community. Well, if you have a population which has higher needs, then, as a principle of equity, you will need to have more professionals to be able to meet the needs of that population that has more needs to be able to have access to the services that they need. So these rules are very important. And again, as I said, the system and the performance and the framework helps us to understand where we are in terms of the inputs in the prison health system, but also in terms of the outputs. And as you can see here in this image, apparently what we have is that, and let me just talk about the health service delivery. We focus, for example, here on the screening for infectious diseases, and you can see that screening is done in almost all the member states for these conditions that you have here for HIV, HCV, HPV-CV, and HPC. And you can see that they are done, but what we also see is that the modality which is used in the countries is not necessarily the approaches that are being promoted by WHO. So while they are there, they are not following the recommendations that we are providing, for many of these screening options. In terms of the outcomes, and you can see it here at the bottom, we see that people apparently die less, in prison than in the community when we consider, all-cause mortality, for example. But if we focus on specific indicators like suicide or overdose, the odds of dying in prison is much higher, for both these two conditions. And this is also very important because this means that we need appropriate responses to address, this very specific cause of mortality. So let me talk a little bit about the inequalities as well and some of the work that we've been doing. We have done a literature review 2 years ago, and we wanted to look at, some of these inequalities and some of the areas where we found that probably, we would have huge disparities between what was happening in prison and what was happening in the communities. So we looked at the cancer. And of course, what we found out was that screening rates are considerably lower in prison settings than they are in the communities, which means that the cancer types that are being diagnosed at a very advanced stage, and thus having an impact in the prognosis and in the mortality or in the mortality rates of people in prison. This can obviously be changed if we look at the possibility to consider doing, screenings and early detection and better interlinks between the Ministry of Health and the Ministry, many times, of Interior and of Justice, so that we can have, more cost-effective and screening for breast cancer, for colorectal, and for cervix cancer. So let me give you some examples now of good practices, because they also exist. They are also very important. And we have been collecting these examples from different areas. Let me start with Portugal, with whom we've